precautions we need to take. Now, the Pioneer Heart Failure study looked at it with around 800 odd patients, and they looked at patients primarily admitted with ADHF with an EF of less than 40. These patients, while stabilized, had a blood pressure of more than 100. They did not have any increase in IV diuretics. There was no IV vasodilators. There were no IV inotropes in the last 6 to 24 hours. This is the group that was taken for the Pioneer Heart Failure study. That means they were stable, they did not go into cardiogenic shock, and they were not in a recurrent or bad pulmonary edema. And then they looked at these patients on the sacubitril versus the enalapril arm, and this was taken over 8 weeks, and this is what they studied. Those patients on sacubitril valsartan had a significant decrease in the NT-proBNP. We must also remember not to use BNP because it would anyway be altered because sacubitril valsartan acts on the BNP by itself. So we need to use NT-proBNP whenever we have patients with sacubitril valsartan. So there was a 29% reduction in the NT-proBNP, which you know is a marker of heart failure, and there was almost a 42% reduction of cardiovascular death or hospitalization for heart failure. And these changes happened pretty early. By the 4th week or so, patients started displaying those benefits. Now, if you look at the breakdown of patients who were actually having worsening versus those who were de novo, most of the patients were patients who were on the ACE or ARBs already had LV dysfunction. And a good chunk was on ACE inhibitors without ARBs, and very few were actually de novo patients. Now, if you look at the change in the NT-proBNP, you can clearly see that whether you had a de novo patient, fresh patient, whether you had a worsening chronic heart failure, whether you had ARB and no ACE inhibitor, or whether you had no ARB and an ACE inhibitor, at every kind of patient, the decrease with the sacubitril valsartan arm was much more pronounced by a significant margin of 20% compared to the patients who were already on the drugs. So therefore, if we were to look at it in a more holistic manner, these are all the patients who should have got ARNI from the word go, rather than trying an ACE-ARB and then getting into trouble and then restarting an ARNI. So this clearly shows that early ARNI treatment and early substitution of ACE-ARB to ARNI is the way to go for the future. Now, the patients who did not have an ACE or ARB, you can see still benefited from the sacubitril valsartan arm. There was a significant 28% reduction, and also you're getting a very robust 48% reduction with the ARNI compared to enalapril in these patients who were not on prior exposure to ACE-ARBs. At the same time, we must also see that both the lines diverge very early, and you're getting some very early benefits within the first 2 weeks.